So welcome everyone to the Special Populations Core 2023 seminar series of the New Jersey Alliance for Clinical and Translational Science. Thank you for joining us for today's presentation. We are very excited to have Dr. Kristen Krause of the Rutgers School of Public Health with us to discuss the role of resilience as a buffer against negative health outcomes among older adults living with HIV/AIDS. Before we jump in, if you have any questions during the presentation, we will have time for Q&A at the end of the talk. So we ask that you please hold your questions for that time. And to get us started, I'm going to turn it over to Jim Lloyd, who's a research specialist here at the Rutgers Center for Health Services Research, to introduce Dr. Krause. So Jim, over to you.
Thanks so much, Kylie. Kristen Krause is an instructor of urban health in the Department of Urban Global Public Health at the Rutgers University School of Public Health, and is the Deputy Director of the Center for Health, Identity, Behavior, and Prevention Studies, which is a leading training ground for LGBTQ scholars. She has expertise in HIV and AIDS, aging, resilience, and broader LGBTQ health disparities. More specifically, her work examines resilience as it relates to biological, psychological, and social health states among older, gay, HIV-positive men. Previously, she was the recipient of a TL1 pre-doctoral fellowship at the Clinical and Translational Science Institute at NYU Langone Health, and also received the Stuart D. Cook Excellence in Research Award for her dissertation work from the Rutgers School of Public Health. Dr. Krause serves as the co-editor-in-chief of a new journal geared toward the health and well-being of sexual and gender diverse communities called Annals of LGBTQ Public and Population Health, and she is also the deputy editor of Behavioral Medicine. We're very excited to have you here, Dr. Krause, and I'll send it over to you.
Awesome. Thank you so much for having me. And hi, everyone. Thank you for joining. I see a few familiar names, so it's always good when I see friends in the space. So I'm going to start by saying that the lovely stuffed things you see behind me are actually microbes. They are all the sexually transmitted infections that we work with at our research center. And I'm saying that just so you don't think I'm the weirdo with stuffed animals behind me, but they actually do have a purpose. So I'm going to share my screen and get started. So again, thank you all so much for having me here. Being part of the NYU clinical and translational science space was a really critical part of my development as a predoctoral scholar. So being able to engage with NJ-ACTS in this way is very exciting for me. So again, I'm just happy to be here. So to kind of take us on just an overview journey and kind of what I'm providing you all with today, a few key learning objectives, is to kind of highlight and delineate resilience as both a trait and a process in a population of older adults living with HIV, and then apply those tenets of resilience and the model that we've kind of conceptualized over the last several years for working with older adults living with HIV, which can then kind of develop strategies that lead us to working with these folks based on a resilience model rather than a deficit approach, which unfortunately is something that I've been saying for a very long time is the kind of dominant approach in public health. So we'll talk about that for a little bit, but just to give an overview background, I'm sure some of you, I know many of you in the space actually have some HIV background, but just to make sure that we're all on the same playing field here. As of a couple years ago, actually, people age 50 and older constitute the majority of people living with HIV in the US. And this is an important demarcation point because a lot of the historical literature would say by 2025, that people who were over the age of 50 would be the majority, but that number was reached much earlier than originally thought. And so when we think about people living with HIV, there are many, history would show us that this is an infectious disease. And in some contexts and in some population, it still is, but it has definitely moved more into the chronic disease space in terms of how it is managed, how it's treated, and how people interact with it on a day-to-day basis. And so when we think about people who are living with HIV, but also those who are aging with HIV, we think of a multitude of biopsychosocial health stressors that they might face. So in addition to many of the comorbidities that we may think about, whether that's kidney functioning or liver disease, heart-related, cardiovascular-related issues, mental health outcomes. There's also just this general way of thinking about living with HIV in general, and then coupling that with the generalized aging process alongside the long-term impact of antiretroviral treatment. There's a lot of things that we are still exploring within this population of people. And a lot of that has to do with we are learning as we go. Given the kind of history and trajectory of the HIV epidemic here, we can see this is a very common graph that is shared in talks that shows the kind of the trajectory of how we've gotten to the point that we're at right now. And so, you know, when HIV was first discovered and it was called a multitude of other things, it was very, very much a death sentence for many people. There was not a scientific sound way to manage HIV up until 1993 to 1995, when widespread antiretroviral therapy was available for people in the US predominantly, but then it expanded globally, who needed it. And we started to see this shift that people were living longer with HIV. We were seeing fewer AIDS diagnosis and fewer HIV and AIDS related deaths. And so I actually recently tried to find an updated version of this, and it doesn't exist that I've been able to find so far. But these trends are still very much the same in terms of the number of AIDS diagnosis and deaths decreasing, and the number of people living with HIV or confirmed AIDS diagnosis has more or less plateaued. I would say, I'm sure we all are aware that many of the data are still being analyzed from 2020, 2021. And so we are inevitably going to see a shift in how this graph looks in 5-ish years from now when we've got more of that data. But we can at least say that things have plateaued for the most part. And so this is one of the more recent, just kind of, again, visual representations that show that people who are at this 50-year-old demarcation point again of age, that the epidemic is graying. And I know that it's still kind of awkward for me being in an HIV and aging space and saying that age 50 is considered old, because I know that's offensive to a lot of folks, myself included, as I'm heading towards that number. But this historically has kind of been that point within the HIV literature that was classified as aging, especially in a time where we didn't know if many people who were diagnosed earlier at an earlier age would make it to age 50. And so, as I mentioned before, there's a lot of things that we're still learning as we go, especially around how we navigate the epidemic, how we treat folks, and how we consistently ensure that people are engaged with treatment and in care. And, you know, as we've kind of moved forward within the epidemic, and a lot of the models have, a lot of the conversation, I would say, over the last 5 to 10 years, especially, has been around this notion of ending the epidemic, due to the biomedical advances and due to the fact that treatment as prevention is kind of this new, more widely accepted approach to the epidemic. That one of the things we still need to figure out is not just from a sole preventative perspective, but if we truly believe that treatment as prevention is the model that we should be using, it's very important to not lose sight of people who are currently living with HIV and how the role that they have to play in this as well. Because we can talk about, and I'll come back to this slide in a minute, but we can talk about, you know, treatment as prevention and undetectable, meaning untransmittable, in the form of pre-exposure prophylaxis or post-exposure prophylaxis for someone who may not be living with HIV, as ways of preventing HIV, but remaining adherent to antiretroviral treatment, again, as a key part in ensuring we kind of get to this ending the epidemic goals. And so what we see here is for people over 55, and again, the CDC is now kind of shifting how we think about aging. So they're kind of moving that benchmark to 55 and older. So this shows us our most recently available data in the US of the HIV treatment cascade is that out of 100 people over the age of 55, 75 of those people have received some form of HIV related care. Of those people, 60 were retained in that care, and then 67 were virally suppressed. And so, as I mentioned again on this other slide, we need to make sure that people who are living with HIV are an active part of this conversation when it comes to ending the epidemic, because one of my fears is that they're being frequently left out of the wider narrative because so much has been focused on preventing new infections. But one way to prevent new infections is to make sure that people who are currently living with HIV have an undetectable viral load. And so when we think about some of the broader complexities of aging with HIV, we know that people are living longer and fuller lives. But as I mentioned, at the start of my talk, that there's many additional challenges of aging with HIV that we're still learning about. So we do know that in general, there are heightened health concerns during older adulthood, both in the form of mental health and neurocognitive health decline. We're still determining and learning every day what the long-term effects of antiretroviral treatment are. And especially for people who are older, who have potentially been on at least several different combinations of antiretroviral treatment throughout their lifetime. At the end of the day, ART is a very powerful drug combination. And so there's still a lot that we don't totally know, how it impacts the overall aging process, how it relates to other comorbid conditions. For this particular cohort of people who are aging, there's a lot of ongoing trauma related to the HIV epidemic. This, predominantly in the work that I'm presenting is definitely focused more on older gay men. And so when we think about just the gay community, the LGBT community as a whole, there was many people lost during the initial onset of the AIDS epidemic. And so many people lost friends, lovers, partners, siblings, community members. And so there's still, ongoing trauma related to surviving that, whether that's guilt, whether that's, just other forms of remembering. I'm not presenting work on this today, but we've had some conversations anecdotally and started to kind of tease it apart a little bit more in some interviews we conducted after COVID, the onset of COVID, among people living with HIV. In a way, many folks were re-traumatized. But on the other hand, many folks kind of were able to take public health messaging around COVID that much more seriously because of what they experienced during their time at the height of the HIV epidemic. And so some other important things to kind of consider how this all relates back. There's still a presence of HIV-related stigma, ageism, racism, classism, sexual orientation, homophobia, transphobia. A lot of these things still very much exist, and the intersection between these things is also something to take into consideration, and that no two people who are aging with HIV are going to have the identical experience. And as I mentioned briefly a few seconds ago and alluded to, with the loss of community member comes the potential for many fragile and fragmented social networks. And so it's important to kind of take this and understand that when we're thinking about caring for older adults with HIV, we can't just solely focus on the infectious disease appointments and making sure that viral load is low and CD4 count is high, which historically has been kind of the focus in for many medical providers and in many approaches. But there needs to kind of be this step back and to think about the physical, emotional, and so in social, albeit holistic well-being for older adults. And so when we think about resilience in particular, I realize I did leave out one important slide, so I apologize for that. But when we think about resilience, there's many different definitions. And this is work that originated within positive psychology. It was work that originated primarily with children. And there's many, as I just said, many different definitions and approaches to how we think about resilience. Some folks think about it as a process. Some folks think about it as a trait. We argue in this work that it's probably a little bit of both. And really at its core, resilience is this ability to bounce back from challenging or difficult situations. And so it's been interesting to think about this in the context of HIV, especially HIV and aging, because as I've said up until this point, there's just been so many things that we are learning as we go. And so now we're at this point that there is this cohort who is still surviving, but also thriving in the face of HIV and have been around since it was this infectious disease. And now it's this chronic condition that people are managing in different ways. And so the work that we've done at CHIPS over the last 20 years and that I've been involved with over the last 9 at this point, has really been starting to tease apart this LGBTQ umbrella, because while we pride ourselves on doing a lot of this LGBTQ work, it is also important to realize that everyone under this umbrella is not the same. And historically, a lot of the work that's been done on HIV, especially in the LGBT context, has been focused on gay, bisexual, and other men who have sex with men, MSM. And so we wanted to kind of take this work a little bit more nuanced and actually acknowledge the importance of sexual identity as a key element in people's lives. And so identifying as gay specifically has a different meaning to somebody than identifying as bisexual or identifying as a straight man who enjoys having sex with other men. And so we were kind of wanting to tap more into the identity side of people rather than just looking at HIV as a behavioral thing. And the term MSM was very much a term that originated by the CDC within the epidemiological literature to define behavior, which is fine. But in this case, we wanted to kind of tap into something a little bit more nuanced and a little bit more important. And so up until I think I first started really working on this hard in 2015, at that point, very few studies had looked at resilience among older HIV positive gay men. Very few studies had looked at it only in gay men. So it was still very much in this like gay, bisexual, other MSM lens. If resilience was being looked at all among people with HIV, there was a lot of studies looking at youth and adolescents, which isn't shocking given the fact that, again, the resilience literature kind of was rooted in children and adolescents. But what we did find in the literature was that people who had self-reported resilience scores that were lower, we also saw higher instances of clinical depression, suicidality, and other mental health distress, in addition to delay seeking care. And so we really wanted to kind of take this resilience piece and kind of figure out how we can start to assess it within this context of living with HIV, to understand more of the mental health and the neurocognitive health outcomes that we know really impact people aging with HIV. And so I'm going to go through these next slides kind of quickly, just because these are just providing a little bit more context and background. But why we're interested in mental health in particular, because in general, we know that about 15.3% of adults over 50 live with a mental illness of some sort, and the prevalence is higher for people living with HIV. And there was a study done a few years ago that looked at comorbid post-traumatic stress disorder and HIV positive women. and it was close to 30%, which is 5 times higher than the general population. And we also see just higher levels of anxiety and depression across the board as well. And another big topic of focus in the HIV space has been neurocognitive decline and disorders, which is certainly more prominent for people who have been living with HIV and AIDS for a longer period of time. And so there's been a lot of different work done on this. There's a few different HIV associated neurocognitive disorders that fall under, that's kind of the umbrella term that's used. So there's asymptomatic neurocognitive impairment, mild neurocognitive disorder, and HIV associated dementia, which is more of the extreme end of neurocognitive decline that we see. And what we know in the literature is that at least ANI and MMD have affected nearly 50% of older people living with HIV. HIV associated neurocognitive decline has become increasingly less common due to the widespread implementation of antiretroviral treatment, which to me is another key point of underscoring the importance of the HIV treatment cascade and ensuring that folks who are living with HIV are retained in their care and remaining adherent to their antiretroviral treatment. And these are just some of the other things that are commonly associated with neurocognitive decline, compartmentalization of HIV in the central nervous system, increase in frailty and susceptibility of age, brain neuro injuries, which are induced by HIV infection, among other things. And so we kind of came to this whole thing thinking about how were we conceptualizing resilience and how were we interacting with it? Because the literature is all over the place. A few years ago, Dean Halkitis here at the School of Public Health, myself and another colleague kind of sat down and drew out this not super complicated theoretical framework, but we were really kind of positing here that the association between, long-term impacts of living with HIV and HIV therapy, combined with the overall aging process, along with psychosocial and structural states. So we're thinking like the phobias and the other stigmas and the other things that we don't always have control over. When we take all of those things into account, that resilience could be have a buffering effect or mitigate the impact on mental, physical, and social health. And we've also, this model doesn't depict it, but have thrown neurocognitive health into there as well. And so this theoretical framework served as the basis for what we call the GOLD3 study. This was the third iteration of the GOLD studies, which kind of built off GOLD1, which was a mixed method study looking at health and well-being, and a community-based sample of men who have sex with men. And GOLD2 built more into a cognitive outlook, where we looked at a care-seeking sample of older men and women living with HIV. And so GOLD3, we really kind of wanted to more or less test this model that we came up with and see whether or not different aspects of it played out in the data that we collected. And so this study actually served as the basis for my dissertation, which, fun fact, I defended on March 12th of 2020. I was the last in-person thing we did at the School of Public Health before the world shut down for a long time. And so we recruited 250 participants in New York City. This work was conducted at NYU, where Dean Halkitis and I were previously at. And so Chips had was a well-known figure within New York City. So it wasn't super challenging for us to recruit these folks. especially given our previous work and some of our other projects. But we had a lot of support from our community-based partners, so GMHC, SAGE. We did a lot of work on dating and hookup apps and websites. We always had teams out at the different Pride events and festivals, book talks, bar nights, whatever the case might be. And we had a lot of people who actually recommended the study to their friends via word of mouth. And so folks had to be between the ages of 50 and 69, be assigned male at birth, and currently identify as male and gay. And this isn't to say that anything outside of this inclusion criteria is not important or not worthy of being studied. But we were, as I mentioned before, very keen in understanding what the gay male perspective on this was. And if we started including other folks, it would kind of dilute that a little bit for the purpose of this particular study. And because we were doing some self-administered neurocognitive batteries, we did want people to have a history of being negative of any traumatic brain injuries, or if something did happen, that their loss of consciousness did not exceed 30 minutes. And they had to be able to come to our research center in New York to participate. So this is just some examples of our recruitment materials. We always try to kind of balance at CHIPS having something that's a little bit more, LGBT friendly and appealing, but also something that's a little bit more discreet, that if it's, you see it on the sidewalk or in a gym or something, that it doesn't just like scream rainbows and unicorns and glitter and all that kind of stuff. And so these are just some relevant measures that we included. And so one of the things that we did, which I'm not going to talk about too much, but we created a HIV related resilience scale, which comprised of these 10 items. And so this was based off of items that were in other resilience scales. As I have said, because there's not a consistent way to define resilience in the literature, shockingly, there's also not a consistent way to measure it in the literature either. And some of the scales that are available were either oddly expensive for reasons we didn't really support, and they really weren't. There's been a systematic review and meta-analysis of resilience scales, and we incorporated a brief version of this, but then given the fact that Dean Halkitis is a psychometrician by training, we decided to kind of, go through this process of creating a scale. We piloted the items with a community advisory board ahead of time. So we kind of settled on these 10 items, which, kind of tap into some of the things I've said in terms of the definition of resilience. So like, I can bounce back from difficult situations caused by HIV. HIV related issues are difficult for me to deal with. Surviving HIV is important to me. And so this work fortunately was published a few months ago. So if you're interested in seeing more of that, this was the first paper of my dissertation. But really the overview of the sample, we were proud that it was pretty racially and educationally, financially diverse. In terms of specific health indicators, the median year of diagnosis was 1992. Close to 61% of the sample had been diagnosed prior to 1995, which was our cutoff point to determine pre-antiretroviral treatment and folks who were diagnosed after ART was available. And we kind of see like a relatively mixed perspective on whether or not folks had received an AIDS diagnosis in the past or had a history of opportunistic infection. One of the things that I do like to note is that 82% of the sample had an undetectable viral load. And while this was self-reported, what we do typically know in the literature is that people, because of the frequency of HIV-related medical appointments, people living with HIV are pretty on top of their status and don't typically miss or misrepresent it in surveys. And so this was kind of just the 4 constructs that came out in the HIV related resilience scale. So it had pretty good reliability across the board, and 3 subscales emerged, which we labeled as adaptive coping, optimism, and effective coping. And so the items that kind of came together on the adaptive coping scale really kind of conformed to the idea that dealing with setbacks and living a new, that people are able to live a new normal life in spite of having HIV. Optimism, really, the items that landed here really kind of showed a sense of survival and hope in the face of HIV, and the effective coping items showed that, by not letting HIV dictate life circumstances or contributing to further difficulties. And so this scale was then used in 2 subsequent analyses. One of them has been published, which was looking at the mental health correlates of HIV-related resilience. And then there's also a neurocognitive correlates paper, which if you ask Dean Halkitis, has not been finished fast enough for his liking. But I ended up redoing some of the analyses after defending my dissertation, so I'm still working on that. But so this is a lot of data, so I'm going to go through it kind of quickly, and then I'll summarize the main findings from the two analyses, and then I'll also kind of show some of the other work that this has been building up to. But some of the main findings here in this analysis involving the mental health outcomes, but also resilience and just general demographic correlates were financial situation and also history of an AIDS diagnosis. So these were things that were eventually incorporated into the final model. But this is really the rich data here showing the correlation and associations between the full HIV-related resilience scale and also the 3 subscales with the different mental health measures that we were assessing. So PTSD, depression, suicidality, substance dependence, and generalized anxiety disorder. And so across the board, we saw significant associations. And so again, this table I'm about to show is a lot, but I will summarize it shortly after. But we can see in the final models that many things across the full scale and the 3 subscales did pan out. And so we also did like a quick analysis to see whether or not HIV-related resilience mitigated or had any type of mediating effect on the impact of HIV-related stigma on the total number of mental health, total number of endorsed mental health disorders, and it did. And so there was, they were all significant associations. But we did see that the full model was statistically significant, so that HIV related resilience did mediate the impact of HIV stigma. And so across those 3 scales, those who had higher levels of HIV related resilience typically were more financially secure and had lower levels of PTSD. Similarly, those who scored higher on the optimism and adaptive coping skills were less likely to endorse substance dependence. And as I just mentioned, HIV-related resilience did mediate the relationship between HIV-related stigma and mental health endorsements. And so we did a very, very similar analysis looking at mental health correlates. And we used the PAOFI, which is a tool to self-examine neurocognitive challenges. And, the literature is mixed. We used it because one, it was a lot cheaper to implement than doing a full neurocognitive battery. But 2, we were actually very interested in seeing how folks perceive their own neurocognitive functioning. And in a lot of literature, it has been found to be not necessarily more valid, but another strong way to assess that. So it included questions like, I can I have full use of my left hand, I have full use of my right hand, and it kind of covered a lot of the different memory, language of communication, sensory motor, and cognitive and intellectual function domains. And so for us, it was a helpful way to kind of assess this. So again, some of the, these are just showing some of the relationships between, self-rated health, race, ethnicity, education, and the neurocognitive outcomes. But then we did also look at the association between mental health and neurocognitive outcomes, which showed us that 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 for the full scale, sorry, yeah, I'm conflating things. So we also did look at these by the resilience scores as well. And so in general, we found that for the full scale and the adaptive coping, that an increase in self-reported sensorimotor and cognitive and intellectual functioning scores were slightly higher, but they were significantly associated with increased levels of resilience. And in terms of optimism, the increased self-reported cognitive and intellectual functioning scores were again slightly significantly associated with optimism in the context of HIV-related resilience. And we saw similar things in the effective coping. And I'm just realizing that these are the incorrect, I included the wrong table. So for that, I apologize, but we did look at these things. So one of the reasons why this paper hasn't been published yet was because the overall relationship between the resilience outcomes and the neurocognitive outcomes were so small, like it was like a 0.2 unit increase. And so we've kind of reconceptualized how we're examining the relationships, because we just didn't feel like it was going to be strong enough to publish as a standalone paper as it was. So that's kind of what I'm still in the midst of. Everything has been reanalyzed, but I'm in the midst of having to go back through and kind of look at the discussion again. But this is also one of the things that you learn as you go. And we were also able to kind of, again, see that the relationship between these neurocognitive and mental health outcomes, just in our sample for older adults living with HIV, we saw some interesting things pan out here around depression and educational attainment as well. And so the study itself was not without limitations. It was a one-time cross-sectional study, so we really are not able to assess anything for causality. The sample, as I've said, came from an urban New York City perspective, and is therefore not generalizable to all HIV positive men living in New York City, but also outside of the jurisdiction. And one of the things that I think I learned very clearly when I lived in Brooklyn and then moved to East Orange, and now I live in Newark, and how folks in the community interact with the HIV epidemic is just not drastically different by any means, but it does look different than New York City, a city that if I turned my head, I could see from my window. And so even though we are geographically proximal to New York, there's a lot of differences in the resources and how things are allocated, how community organizers kind of come together and advocate. And so these are just things that, we've seen firsthand after moving the research center over here to New Jersey. And so there were many strengths. It was an original data source. And the fact that it was one of the first samples of self-identified gay men that was sociodemographically diverse. We did include, various measures of resilience. So we were kind of able to really look at it holistically and understand that, this measure we created was a valid and hopefully in the future useful tool for others to include in the work that they're doing around resilience. And it was able to kind of test this theory in a way that we hadn't been able to do before, which has now led to, other conversations around biopsychosocial health outcomes. And so I am mindful of time, but I did want to highlight kind of the work that sparked kind of sparked by the Goal3 study is when we came over to Rutgers from NYU, we were really committed and interested to see how this work could be operationalized in a place like Newark, that, as I mentioned, is very close to New York City, but also very, very different in many ways. And so we decided to put together a qualitative interview study to kind of have folks conceptualize themselves what resilience means. Because we were doing this work in Newark and we were still kind of trying to get our footing. We didn't have a lot of strict inclusion criteria. Folks just had to be over the age of 50, identify as HIV positive, and live in the Newark area. So we did enroll both men and women. The sample was relatively split. I believe we had 18 women and 22 men participate. And so we really focused on, the general process of aging with HIV, aspects of resilience and advanced care planning. And so specifically around resilience, we did ask each participant, basically, in your opinion, what is resilience? And if we did follow up with a prompt, is what does resilience mean to you as a person living with HIV? And so there was some interesting, what I will say is that this was the focus of the study originally. And after we started transcribing and coding and really reading through and coding the interviews, it was interesting to see how many other, I would argue, almost more prominent things came out of these particular interviews, that I'm very excited that our team is, if you've done coding qualitative research before, you know how long it takes. So we're still actively working on some things, but the quotes I'm about to show you actually are our resilience-based quotes and will be featured in a book chapter on aging invisibly later. I think it should be coming out later this year. I lost my mouse. And so the first theme that kind of came out of this was around health and sobriety. So someone said, my resilience for being diagnosed is to believe that I could still live with the virus. I bounced back. I bounced back from 2 T cells to now 100. And if you do the footwork, you'll get the results. And someone else said, the ability to come back from a very terrible situation, and me being in this situation that I'm in now, like I was saying, I was a mess. I was HIV positive. I had sepsis. I had no T cells in my body. My viral load was over 750,000, and I was wondering, and the doctor was wondering, why am I still walking on this earth? And so after that, I knew I had to decrease this viral load. I knew I had to bring my viral load down so that I would take my medicine every day. Another theme definitely revolved around spirituality. And I thought this was one of the most poignant quotes that we had, to really bounce back, to rise from the ashes like a phoenix. Yes, and I have risen from the ashes. I mean, I'm at a place right now, especially after losing my mother and sister, it would not take much for me to go left. I'm holding on to God's unchanging hand. I'm holding on to what strength I have left because I have to, because if I don't, I'm going to lose it. So I'm staying strong, staying in my truth, as the kids would say, and I'm staying in my truth, and I'm bouncing back. The best way to describe it is like being a phoenix rising from the ashes. And the final theme that emerged from this particular set of data is around positivity, thriving, and living in the moment. And so resilience means to me that I have to overcome a real bad negative attitude towards everything and everybody. When I found out that I was positive, I realized that I couldn't live like that anymore. I couldn't keep walking around with the attitude, wanting to fight, cussing and carrying on. It was just not me. So I turned that negative into a positive. And now I want to help people. Back then I didn't want to be bothered by nobody. I didn't want to help nobody. I didn't want to talk to nobody. But now it's like I can talk about it today. I can help people today with it. And finally, again, when we asked folks to kind of define this, they said positive, good things, growth, maturity, respect, and to treat others how you would want to be treated. And when prompted about why they chose those words, they said that I chose those words, those phrases, because I use it every day in my life. And I try to be an example of that and to give that fact, because as people gave it to me, and it's not enough for me just to keep it and be selfish with it and don't want to share it back. And so, as I mentioned, we're still actively analyzing a lot of the other data that came from that Gold 4 study. We've got some really interesting things around advanced care planning that, I kid you not, this morning started percolating into a whole potential grant submission in my head this morning. Because when we think again about aging with HIV, so many of these people did not, especially when they were diagnosed earlier in their lives, they did not necessarily plan to age with HIV. And so a lot of conversations that are normally had about retirement and leaving assets and making funeral arrangements and final wishes, a lot of people haven't actually thought about that, because it's been this constant need to just survive and to just make it to the next day. But now that more people are not only surviving, but they're thriving, we need to start thinking about how do we make sure that people who are aging with HIV have the long-term support that they need and the necessary things in place, so that it's not something they have to like worry about as they get to that later point in life. And so that's what we're working on right now. And some of the other future directions that really kind of come from this is continuing to push public health, especially from a deficit-based to a strengths-based approach. And as I mentioned earlier, psychologists and even social workers, especially those who have been truly community-based, they've been doing this work for decades. And so we know that resilience is definitely an underutilized approach. And we still need to figure out on how exactly can we build interventions that tap into resilience, now that we know that this exists and that we can see these correlations and see these outcomes. We have to figure out how we can kind of take it the step further. And also understanding the gap between the health of populations and individuals, and knowing that there are certain things that happen at the structural levels that have that effect there, but then also need to figure out how to support those at the individual level as well. And in general, care and services for older gay adults, but also older LGBTQ adults in general, are very limited in the US. There are certain organizations that are doing this work very well, but they cannot be the sole responsible party for ensuring that adults age successfully, LGBTQ adults age successfully here. And really, as I started off by saying, ending the epidemic is such a huge catchphrase at this point now when we talk about HIV, both here in the US and abroad. But I will continue to shout from the rooftops that we cannot leave people who are currently living with HIV out of these efforts. They have to be included in the conversations. And when we also think about what the role of COVID has been over the last couple of years, what can we learn from history? How can we apply these lessons to future pandemics? And how can we ensure that this care is actually equitable? And so this is just some work that as an early career researcher, it's always exciting to write op-eds, but when Reuters asks you to do it, you drop everything and you do it. So this was a piece that came out about a month ago, where again, I'm kind of like calling attention to the fact that resilience is a crucial part of ending the HIV epidemic overall. So here are a few resources, and I know this is being recorded, and happy to share slides after, but just some of the resources available on HIV and aging, and just some acknowledgements. This work is not done alone. These wonderful people who you see in this photo, I have the pleasure of still working with many of them, and not only now as previously as mentors, but now as colleagues. And we've got an amazing team of interns and research assistants who helped collect this data, our community organizations who helped recruit and helped us gain legitimacy within our communities. And so we're just always grateful for the support that they have, because we would not be able to do the work if it wasn't for their trusting presence and just overall greatness. So this is my contact information, and I know we've got a little bit of time left, so I'm happy to have a chat or answer any questions.
Yeah, if I could start. I think it's really fascinating to apply this to the aging individuals with HIV. I mean, I'm familiar with it from, kids and overcoming ACEs and that kind of stuff. And I was curious about kind of what your thoughts are, either around things you have found or things you think you might find, with respect to the places where these people are getting care and things that they could do to help improve and promote resilience among that population.
Yeah, I think that's like kind of the next step, right? And there's definitely some Mackie Friedman, who just joined the School of Public Health at the beginning of the academic year. Some of his team and his work has been kind of looking at how do we intervene on resilience, because it's a really big and abstract concept to think about. Even I struggle a lot of times. I'm like, it's easy to think about like needle exchange programs because that's a tangible thing. You're giving someone something, they're exchanging it for something else. But it's like, how do you, if we can't even agree on how to measure resilience, how do we intervene on it, right? Like, so the thing that, kind of what I said at the end it's a wider conversation, and one that I feel like I have everywhere, is like really kind of shifting how we think about even public health. Like, we are so focused on what people do wrong, not even like not just counting HIV. We focus on bad behaviors. We focus on the things that inhibit people's health, right? Like, even if you go to the doctor, like, even I'm guilty of it. Like, I'm always like focused on like, oh, I didn't take my medicine all the time like I should have, or I didn't really do this. But there's other things I've done. There's other routines I've incorporated into my life that could be contributing to positive health outcomes. So when we just shift how we think about it, and it's hard within medical settings, we ask so much from our medical providers as it is, in a structure that's not built for this, right? So it comes with figuring out at different levels how we can interrogate this concept, because it's an all for one effort. It can't just be one medical center. It can't just be nurses. It can't just be doctors. It can't just be social workers. It's got to be how we think about it, which I think is larger than all, 9 of us here, 8 of us here.
Yeah, Emily, you have your hand up.
Hi, thank you. I'm trying to lower my hand and also unmute and everything. Okay. Hi. Yep. So I'm Emily. I'm from the Rutgers School of Social Work on the topic of interprofessional practice and different disciplinary starting points for this work. And I'm just wondering, Kristen, I'm so glad you're working at the intersection of aging and health of minoritized populations by gender and sexual identity. I have colleagues in the school who do work not in aging, but also on the health aspect. And I just wonder, like, in your future grant activity and projects and in your past work, how are you leveraging interdisciplinary teams to be able to puzzle through these really important, long-standing issues
Yeah.
and opportunities?
Yeah. So that's one of the things that I've been an instructor now for 1.5 years. So the first year I feel like I was just trying to get my footing. And how do you be like, no one teaches you how to be an instructor, how to be a professor. And so some of the things that I've been doing most recently, I applied for a few smaller grants to actually use the All of Us data that the NIH has put together. And so I'm really interested. One, I'm very tired. I think we all are, but I'm very tired of running studies right now. So, and we just have so much data from these studies that I've talked about and some of the other studies that we've done that I just want to sit with it for a little bit and analyze it. But I need to still write grants, and I need to tell Rutgers why I should stay here. So I've been really interested in the All of Us data because I do find it to be a very unique way of approaching some of these topics. For those of you who don't know, All of Us is like NIH's prized child now. They've reached, I think, 250,000 enrolled participants or data available now. And so there's a lot of data available on HIV and aging. So part of what I've been trying to do with some of my baby smaller grant submissions is to bring a couple folks from IFH actually. Olga served as a mentor on one of my applications. And so working with her from like the gerontology perspective, and also the nursing perspective. But then I've also brought in a colleague on the proposal from genomics who's got a genomics background, because All of Us has all of these genomic markers available. So one of the things I'm interested in looking at moving forward is the relationship specifically between Alzheimer's and people living with HIV, because it's so understudied. And so I'm always open to collaboration with folks at the other schools. I know this is being recorded, and so I know I should watch what I say, but part of our like being in different chancellor units is like how our P&T guidelines are. And so sometimes it's not always incentivized at the lowest level, the baby level. But I'm doing it in any way that I can. And so by starting to, build relationships with some of the folks at IFH, I've been really excited about the possibilities, and just doing some of the work with the folks at social work, working on like the LGBT MPH MSW concentration. I've been part of that work too. So I'm always trying to expand the network in every way possible.
That's great to know. I'll follow up with an email that I think I can
Yeah.
maybe make some connections. And
Yeah,
sometimes
I
it's
love
not
that.
even sharing dollars. It could just be sharing data, sharing students, sharing ideas.
Yeah, and we've got
Right.
so much, especially from that qualitative data.
Mhm.
There's a lot there that, if folks were interested in, I'm happy to kind of bring them in, because I think there's a lot there that we haven't touched on yet. And for the advanced care planning, I'm bringing in some poli-sci perspective too, because I think we could talk about advanced care planning all we want, but I think there needs to be like actual policy changes. So that's kind of the angle I'm forcing that paper to go, because I could get it into a social service journal, I could get it into something, but the people who like need to see that this is a problem know it's a problem. It's the people who it's the people who don't realize that it's a problem that need to see it. So yeah.
Amen.
All right, well, we are at the end of our time. So I just want to thank you all so much for joining today. And of course, thank you, Dr. Krause, for sharing this important research and your expertise with the NJAX community. We're so grateful for it. Thank you again, everyone, for joining. Take care, and we'll see you at the next seminar. Have a great day, everyone.
Thanks, everyone.